All right, this is the cardiac review, part 3. Somehow part of that presentation from 2 got cut off, so we're going to start with left-sided heart failure here. So blood backs up into the lungs, causing lung symptoms: pulmonary edema, dyspnea, orthopnea, cough, crackles. Can't palpate this, you need to auscultate. Frothy sputum that can be pink. So, left-sided heart failure. Left ventricle is not pumping out enough. This may lead to less blood flow to the kidneys, impaired kidney function, elevated BUN. Now, BUN is a test of kidney function, so is creatinine, and creatinine is very specific to the kidney function, where BUN can be from dehydration or other things. So, but both are kidney tests, BUN and creatinine, but the creatinine is a little bit more specific. So less oxygen to the brain can cause fatigue, restlessness, confusion. So here's a nice little image of left-sided heart failure. See, they have the orthopnea, they're leaning forward to breathe better. Remember, left-sided, left lungs. The left-sided heart failure affects the lungs. Left-sided heart failure, blood comes from the lungs, so when it backs up, it affects the lungs. Left lungs. In from the body, out to the lungs, back to the left side from the lungs, and then out the left side to the body. Symptoms of right-sided heart failure. So this backs up to the body, dependent edema. So when it's dependent on gravity, when they lift their feet up, it gets better. So like 3-4 plus edema here, hitting edema. So there's going to be weight gain from the fluid retention. We're going to have organ enlargement. The enlarged liver is it's hepatomegaly, enlarged liver, and GI discomfort. Anorexia, jugular vein distension, nocturia, frequent urination at night. Enuresis is bedwetting, that's totally different. Lying down aids in venous return from the legs. So they don't have that dependent edema anymore because the legs are elevated. The edema has the fluid from the edema returns to the general circulation, and then there's more fluid to the kidneys, more urine produced. So yesterday's edema turns into tonight's bathroom trip. Good short answer. In men, what's another more common reason for nocturia? And BPH, benign prostatic hypertrophy. So, it's an enlargement of the prostate. This is not prostate cancer. And there's a blood pressure medication that they can actually give to relax the muscles and help this blood flow a little bit. Right-sided heart failure. So right-sided heart failure is going to affect the body because that's where it came from. They say it has ascites, fatigue, enlarged liver and spleen. So how do we diagnose this? Symptoms. Patient has fatigue, weight gain, and do a chest X-ray looking for a large heart or fluid. Check the jugular vein distension. EKG. They could have had a heart attack and never even known it. An echocardiogram looks at ejection fraction and the valves and their function. BUN creatinine levels. Remember, the creatinine is a little bit more specific to the kidneys. So kidney function and cardiac output. The BP is related to the PP. If kidneys don't get good blood flow, they don't work. And then the levels rise in kidneys, not when kidneys are not functioning properly. So you have elevated BU and elevated creatinine. So everything gets filtered. The little nephron, functioning unit of the kidney. And then this is the glomerulus, and this is where everything gets filtered. So when you're looking at kidney function, you're looking at the glomerulus filtration rate, or the GFR. So thyroid, hypo or hyperthyroid can affect heart function. BMP is a hormone produced when there is overstretching or dilation of the cardiac ventricles, similar to a diuretic. So produced by the ventricles when they are overstretched, like in heart failure. And it's a blood test. So diuretic effect of BNP, vasodilation, BNP produced in the ventricles, aldosterone inhibition, and then diuresis. So you want to look for a level of 100. That's pretty much a diagnosis. Don't confuse BNP with BMP, which is a basic metabolic profile. How do you treat it? And reduce the workload of the heart by getting rid of excess fluid, reducing the blood pressure, and letting the body rest. Pace activities. Assisted devices, wheelchairs sometimes are needed. Adequate sleep. They may need pillows. And limit fluids before bed so they don't wake up to urinate. So, if heart failure leads to fluid retention, our goal is to limit foods that cause edema or fluid retention. So I think we all know what it is. It's sodium. Sodium, salt, no snacks. So sodium should be about 2.5 grams a day in the average adult. 1 little teaspoon contains 2,300 milligrams, or 2.5 grams. So 1 teaspoon of salt is your daily max. Avoid high sodium foods. So canned foods have high salt. It's like an N-Cletano thing. Canned foods, cheeses, condiments, and I think that's pretty much given. So some people are put on a 2-gram sodium diet restriction. Need to be aware of other sodium sources. Some people will take a salt substitute, but then look, it has a bunch of potassium. Mrs. Dash, no potassium. Pretty much no potassium. Most people with heart failure are on a diuretic, like Lasix or hydrochlorothiazide. Most people with heart failure try to restrict sodium, so they're taking a diuretic, which may hold on to potassium sparing diuretic. They use salt substitute, which has excess potassium. So then they're using a potassium sparing diuretic, like aldactone. They could end up with high levels of potassium or hyperkalemia. So these are not potassium sparing, these are potassium sparing. Treating supplemental oxygen, nasal cannula or mask. Need to know the patient's baseline pulse ox. You want to keep them at 22 or higher. You may need to titrate. Titrate is just increasing until you get to the desired level. Assess fluid gain or loss. Daily weights, pints a pound around the world. So a gallon weighs 8 pounds. If somebody gained 8 pounds in a week, that is a whole gallon of fluid. Daily weights. Should be at the same time before breakfast, first thing in the morning. It needs to be a calibrated zeroed scale. Same clothing. So 2 pounds in a day or 5 pounds in a week. So remember, 5 pounds is over half of a gallon of water. 2 pounds in a day, 5 pounds in a week. Fluid retention means excessive fluid volume or fluid volume overload. It means you need to adjust the treatment. Sometimes they have to do surgery to fix the underlying problem or cause. So there's mechanical valves, and then there are organic valves. So this is from a pig, this is from a cow. So when you're looking at INR therapeutic levels, and they have a heart valve, it's important to know whether they have a mechanical or non-mechanical. A lot of medications, diuretics, get rid of the fluids, potassium replacements to replace potassium from the non-potassium bearing. So if it's a diuretic that's not going to hold on to, tell the kidneys to hold on to the potassium, and it's going to get rid of a lot of potassium, then you have to replace it. Digoxin, ACE inhibitors, beta blockers, fancy IV medications. No diuretics. Gets rid of water, diuresis, your urine, Lasix, which is furosemide, and fumethidine, thiazide diuretics, hydrochlorothiazide, and you tend to lose potassium because these are not potassium sparing. But you still need to monitor the potassium because it could get too low. So the general rule of thumb is 3.5 to 5.5, and this is one of those labs where it could be 3.5 to 5, but generally 3.5 is the low standard rule. So know the ballpark for these. Like an NCLEX, you're not going to get 5.3. You should get like 4.9 or 5.9, so it's not to confuse you. Potassium sparing. Aldactone. Don't lose the potassium. Your kidneys hold on to it. And then if you take salt substitutes, there's even added potassium. So you're going to hold on to all your potassium, and then you're going to have a salt substitute that has potassium, so then you're going to have hyperkalemia. And then that could lead to dysrhythmias because the heart is a sodium-potassium pump. Hyperkalemia, hypokalemia, high potassium, low potassium, arrhythmias or dysrhythmias. K-Tab is one brand of potassium replacement, and you can get it from dietary sources. Orange juice, potatoes, bananas. It's my justification for eating French fries. Bananas, orange juice. Winter squash, spinach, cantaloupe, skim milk. Yeah, you don't want the chips or French fries. Digoxin slows heart contractions and strengthens the heart contractions. This increases the cardiac output by allowing the heart to feel better. So there's gonna be more volume in each contraction, so that's going to increase the effectiveness of the heartbeats. So digoxin. There's some important things to know about digoxin. You need to check the heart rate, just like beta blockers or other blood pressure medications, but you really, really need to check the heart rate. If it's not 60 or above, then you probably should hold it and let the provider know. So why are elderly at risk for drug toxicity? And this is not just cardiac meds, this is all meds. Most drugs are metabolized in the liver. Most drugs are excreted in the kidneys. When we get older, both organs work less effectively. So if you're not metabolizing them as quickly as when you were younger and you're not excreting them as quickly as you were when you were younger, then you're going to have a buildup of these medications in your body. So you could have toxicity. So you need to look for, this is all about digoxin toxicity. Bradycardia, slow heart rate, and fatigue. Anorexia, abdominal pains, nausea, vomiting, visual problems. So one thing with digoxin, and this is a really good and key point, with digoxin toxicity, you can have yellow halos around the eyes. You could have low potassium levels may increase the toxicity, the chances of toxicity. So, it's a double problem there. This is a nice little image. So, normal digoxin levels are 0.8 to 2.0. So, the toxic levels of digoxin and lithium are 2.0. So 2.0 higher. And theophylline is 20. Theophylline is a respiratory medication. ACE inhibitors, or the PRILs. I like to call them APRILs, like ACE PRILs. So, angiotensin converting enzyme inhibitor. So, angiotensin 1 converts to angiotensin 2, but these medications prevent that from happening. This is all leads to increasing blood pressure. Main effect is to decrease blood pressure. So easier for the heart to pump all that blood out, move the oxygen around the body. So this decreases blood pressure. Easier to pump blood out of the heart. It's a lot easier to move things when it's less crowded. Some examples: PRILs. Captopril, lisinopril, pril. So a lot of hypertensive medications cause dizziness. Be careful standing up. This is more so with beta blockers than the rest, especially when you're just starting a patient on a beta blocker or they had a change in a dose. Be very careful standing up for a few days. That could lead to orthostatic hypotension. Make sure you look up orthostatic hypertension. There's 3 positions you check blood pressure, and how much difference do you need to have in those blood pressure ratings for it to be orthostatic hypotension. So an ACE cough is pretty common. Dry, hacking, persistent cough, just all day long, every day, it does not go away. Most of the time, this will show up in the first couple weeks that a patient's taking this, but it can show up months later. And you have to switch. And the class of blood pressure med that's the most similar to ACE inhibitors are the ARBs, and those are the ones that are sartans, so like low sartan, so they would switch from an ACE to an ARB. You don't keep taking it, that's for sure. Beta blockers. So epinephrine and norepinephrine affect blood pressure and heart rate. It's like the fight or flight, epinephrine, adrenaline. It's the same thing as adrenaline. So the beta blockers block the effects, the receptors. So it decreases blood pressure. You have metoprolol or Lopressor, LOL, propranolol, Inderal, LOL, beta blockers. Beta blockers are funny, LOL, and atenolol. Just like Jackson, need to be aware of that heart rate and blood pressure, and it could cause impotence in them. Never stop the beta blocker quickly, and remember, orthostatic hypotension is more common with beta blockers. Fancy IV medications. So this is an acute setting, ER, ICU. This is not in a clinic or a nursing home. Remember we learned about BNP. Remember producing the ventricles when the heart is overstretched, and it's like a diuretic. It allows the tub to empty, so it tells the kidneys to get rid of fluid. Aldosterone. This is the adrenal glands, kidney, diuresis. So this BNP can be made in a lab, and then it causes diuresis. Dopamine. This is a crash cart drug. So dopamine is given when you want to increase the blood pressure because their blood pressure is too low. It could be too low for lots of reasons. It could be from shock. So given in a very low dose in heart failure because it improves blood flow to the kidneys, and it's a diuretic. That's it. All right. Look for respiratory videos soon and skin videos, and I might do some review questions for this MedSearch 2. If you enjoyed the videos, thank you.